So, first session is by Dr. Sadaf. He will be speaking on optimization of the jaundice treatment for interventions. Dr. Sadaf, she is a renowned surgical gastroenterologist at Kashmir, and she has been an active participant for all the conferences and academic events which we have been seeing for the last few years. And so I invite her to deliver a talk on optimizing the patients.
Worthy chairpersons, senior faculty, co-faculties, student, president, IASGO program present with us. A very good afternoon to one and all. And I would straight away go to the topic assigned to me is pre-procedural optimization of jaundice patient. As you all understand that taking one topic with different areas lead to a lot of overlap. And we have been going through this metabolic formation of bilirubin or generation of bilirubin right from this instant RBCs to its secretion into biliary tract by previous speakers. And once in biliary tract, it is delivered into the duodenum, wherein majority of it is excreted as stercobilinogen and stercobilin in the stools, and a little and re-enters into enterohepatic circulation, and a subtle amount is then excreted into urine as urobilin. So when you look up at a jaundice patient, there are, sorry, this is gone. Yeah. Slide show nahi karna. So we look up at a jaundice patient with many possibilities in our mind, and then we tend to put it into the misnomer of surgical or medical jaundice. But basically, there are three variants: the pre-hepatic, hepatic, and the post-hepatic. And whenever we talk about optimizing a patient, we are by and large talking about those patients who need an intervention as a part of definitive treatment. And these patients are the post-hepatic jaundice patient, wherein you have dominantly increased amount of conjugated bilirubin with presence of bilirubin in urine as well as bile salts. So these are the three different variants, wherein most of the patients of pre-hepatic are referred to the clinical hematologist for subsequent management. Maybe some patients would come for surgical and endoscopic intervention. The hepatic jaundice with various causes of hepatitis discussed since morning are basically treated by antiviral drugs and proper follow-up protocol by medical gastroenterologists. And the post-hepatic jaundice are the group of obstructive jaundice patients due to any benign or malignant causes which are more complex to be managed and need optimization before a definitive relief of obstruction by surgical or any procedures. All these patients have mild to severe pathophysiological changes occurring depending upon the severity of hyperbilirubinemia. So optimization of this patient is very important, especially once there is moderate to severe jaundice. Most common scenario in this patient would be obstructive jaundice requiring an endoscopic clearance of stones, structure dilatation, deployment of stents in biliopathy or advanced malignancy, and a subset of patient where the disease is operable, you need to go for surgical intervention and remove the tumor in ampullary, periampullary, or a CVD area, even liver resections. The less common scenario is those patients which have hepatitis or cirrhosis. Due to one reason, the other may be requiring the surgical intervention. Say it may be only for due perforation, appendicitis, HCC, an obstructed umbilical or an inguinal hernia. And the least common is just the previous speaker discussed is the lose-lose situation of fulminant hepatic failure, where you have to take a call between emergent liver transplant to best supportive treatment. So all these obstructive jaundice patients, you have gone into the clinical presentations, how do they present? And there is failure of bile to reach into the duodenum, and pathology would be anywhere from the hepatocyte right up to the ampulla of filter. There are complex pathophysiological changes which would, if jumped into surgical procedures, would lead to wound infection and delayed wound healing, bile leakages, and bleed. This is a very good article for going into details of pathophysiological consequences of obstructive jaundice and its perioperative management in HPD International. What exactly happens in these patients is, due to obstruction of bile or no bile reaching the small bowel, there is a lot of overgrowth of bacteria, atrophy of the mucosa, there's altered mitosis and apoptosis sequences, loosening of the junctions, and ultimately lead to endotoxemia in both portal and systemic circulation. There will be cytokine response, oxidative stress, and what the end organs would be affected are the renal system, the cardiac system, and the vascular system. And of course, the gut is the genetic point of pivotal time, which also gets affected. So the principal manifestations of these patients can be with hemodynamic instability, acute renal failure, cardiovascular suppression, immune compromise, coagulation disorders, nutritional impairment, and wound healing defects. And these patients, if not prepared well, can have as high morbidity as 20 to 30%, which you can cut short to 10% or less if they are taken up with proper optimization. The vascular hyperresponsiveness, volume depletion, and cardiac depression, which is cardinally known as jaundiced heart, actually occurs due to direct bile interferences. The volume depletion is also because of loss of thirst, increased ANP, and diuretic natriuretic effects of bile salts, leading to end result of vasodilatation, and there is very decreased responsiveness to sympathetic stimulation. So what we need to do is we need to maintain an effective circulation with fluid administration as a preventive measures to decrease the mortality and complications. The basic aim of the fluid administration has to be increase in left ventricular stroke volume, avoiding any cardiopulmonary complications simultaneously, and avoiding any interstitial edema. Both excess and inadequate fluid would be problematic in these patients. Even in patients who need interventional treatment, as little as clearing up of a CBD stone or one or two few single stones, an overnight fluid therapy would maintain an adequate vascular volume and would avoid renal dysfunction formation. Then you also need to optimize the renal functions of these patients, because these patients can have acute renal injury or pre-renal azotemia because of the enteric endotoxin into circulation, the fluid shifts, and the depressed cardiac functions leading to hypoperfusion. There's also direct injury by bile acid, which creates a cast in the renal tubular system, leading to acute tubular injury. So what we can do for these patients is we have to prevent hypovolemia. We have to avoid using nephrotoxic drugs. We have to have daily monitoring of intake and output, renal function, and electrolytes, and given fluids according to that. And sometimes you may require flushing of the renal system with mannitol. But once the ARF is actually set in, then nothing can help other than restoration of bile into the duodenum. Then there are complications or malabsorption issues which have to be tackled due to malabsorption of fat and fat-soluble vitamins. Then the most important of those is, other than vitamin D, E deficiency, A deficiency, would be vitamin K deficiency, because a lot of homeostasis is dependent on vitamin K deficiency, as well as hypoalbuminuria is important, especially in the subset of patients whom you are planning to operate with a major surgical intervention. These patients, you should try to maintain albumin level of 30 grams per liter, and coagulopathy should be corrected with 10 milligrams of vitamin K every day for at least 3 days before intervention. The malnutrition issues have to be settled with replenishing of the nutrition, preferably by enteral pathway. You may have a combination of patient and subset where you have choledocholithiasis, pancreatitis. You might have to put it a nasojejunal tube to supplement nutrition. Sometimes the patient may have severe anorexia related to malignancy, vomiting, and some other issues, ileus, wherein you might have to initiate even TPN. I suppose this is also to be taken up as a separate subset of discussion in your today's academic program. So another important issue is there would be infection due to bacterial translocation, again, because of the loss of barrier mechanism, regress of the bacteria into the biliary system, discussed in detail regarding cholangitis and its grade. But majority of the time, the bacteria to be addressed are the gram-negative ones, which include E. coli, Klebsiella, Proteus, and Pseudomonas species. The gram-positive organisms mainly are the Streptococcus and Enterobacter species. Beta-lactam inhibitors combined with aminoglycosides, of course, if your renal parameters permit, is a good antibiotic to be started empirically. Quinolines and carbapenems are better monotherapy, which can be initiated to treat cholangitis. Now, once there is a suspicion of enterococci or anaerobic infection, you have to target it with change in your antibiotic protocol, especially those who have antibiotic resistance to the previous treatment, those who have previous biliary intervention, and very elderly patient. Again, very important, it has been discussed thoroughly that no antibiotic is likely to control severe sepsis unless and until effective biliary drainage is reestablished. So the pillars of preparing a patient for procedure or surgery would be accurate diagnosis, which you already have gone through, correction of pathophysiological issues to extent that is feasible. And of course, the third important thing is assessment of and stratification of risk related to procedure. So many of these patients may be having a concurrent stigma of chronic liver disease. These patients, if they are actually into child's B and C cirrhosis, the mortality related to procedure would be very high. So you have to look into signs of concurrent portal hypertension, ascites, hepatorenal syndrome, portopulmonary hypertension. Simple child's pulse coding system can be a good guidance for planning an intervention. What intervention would be optimal for which patient? Other risk determining factors, which in clinical practice would guide you about obstructive jaundice, would be a pre-operative hematocrit of less than 30%, bilirubin of more than 200 micromoles, and malignancy itself is a significant risk factor. So is important the severity or type of surgery which you are going to plan for your patient. If there's a very major surgery to be planned on background of chronically diseased liver, then you have to take it with a pinch of salt as compared to simpler operations like cholecystectomy, bypass, and biliary drainage. When the risk is very high, a non-surgical decompression of the system would be important as compared to extensive surgeries in cirrhotics. Even when we plan as simple as cholecystectomy, you might have to do just cholecystostomy. Again, the nature of surgery done electively or emergently is very important to determine mortality and complications in this subset of patients: obstructive jaundice, CLD, a combination of two. And then you have already discussed that some patients an immediate unwaiting drainage of biliary system should be done, especially in presence of acute kidney injury, severe sepsis, concurrent liver abscess, cirrhosis, high strictures, and very elderly patient. These patients, by and large, the presence, as Professor Saraswat said, that with hypotension, altered mental status, respiratory failure, renal failure with creatinine of more than 2, greater INR, and low platelet. So in this emergency scenario, there's a belief that you tend to decompress the system better with ENBD. Other options are EBD and PTBD. And all these procedures should be done under prophylactic antibiotics. Next lecture would be coming up about where all you should and which patient and what type of biliary drainage should be done. So I won't go into details of all these things, but by and large, as we were discussing previously, we avoid drainage once we're anticipating as not planning a liver resection. But if there has to be a cutoff, that it is 150 micromoles. And once we're anticipating the liver resection, hepatic reserves are very important. You might have to plan it further. So in short, I would end up with a take-home message of you can actually mark a difference in overall outcome by optimizing this patient, decreasing the mortality and morbidity. Majority of the time, it is the obstructive jaundice which needs optimal preparation. Electively done procedures after preparing the patient well is important part of the management, which could include volume repletion with appropriate fluid and electrolyte therapy, addressing renal dysfunctions, pre-renal azotemia, HRS adequately, correcting the coagulopathy with vitamins, and if you're planning a procedure, you might have to use some plasma factors as well, giving good nutritional support to the patient, and controlling infection with appropriate antibiotics. There are very few instances of severe cholangitis and renal failure where you cannot wait much, and the optimization begins with biliary drainage. Risk stratification when anticipating surgical treatment is very important in both for managing doctors as well as understanding of the patient about the outcome. Patient requiring operative resection surgeries, routine preoperative biliary drainage is controversial. And there is general consensus that when a major liver resection is anticipated, the bilirubin level should be optimal. Thank you for your patient hearing. I would like to invite all of you to an upcoming ISPBA conference that we are organizing at Sher-e-Kashmir Institute of Medical Sciences next week on 18th and 19th of March.
Thank you, sir. I invite you for to chair the next session. Next session, we have the most eminent speaker for today. We have Professor Dr. Ender Dulundu. He is a specialist in liver surgery, in bioduct and pancreatic surgery, expert of liver transplant, and a vast field of oncologic experience. He is an undergraduate from Istanbul in 1990 and then did his postgraduate in 1999 from PC Ministry of Health, Istanbul. Subsequently, presently he is professor at PC Ministry of Health at University of Pendik Training and Research Hospital General Surgery Department at Istanbul since 2016. He has huge list of publications, presentations in the international conferences and international journals. Just to cut them short, presently he is the president of IASGO. IASGO is an association of International Association of Surgeons, Gastroenterologists, and Oncologists brought together under one roof. And they have a World Congress which he'll be telling subsequently. And his present topic for today is a pre-operative biliary drainage, which has been a quarter point for all the surgeons whenever we are planning any surgical intervention. So I hand over to Professor Dulundu.
Thank you very much, Chairman, for your very kind introduction. Before starting to talk, I would like to thank to Professor Kapoor and organizing committee for inviting me. It's a great honor and pleasure for me to be in this beautiful country and to meet with the excellent people for the first time in India. In obstructive jaundice, patients are at risk for associated coagulopathy, malabsorption, malnutrition, and impair of hepatic, renal, and immune functions. And it was hoped that preoperative relief of jaundice would correct this defect and decrease postoperative morbidity and mortality rates after the surgery. However, the available data from the randomized trial of preoperative drainage versus non-drainage are conflicting. The management of malignant tumors that may cause biliary obstruction are pancreatic cancer, cholangiocarcinoma, ampullary carcinoma, gallbladder carcinoma, and metastatic disease. As for the indication for palliative biliary drainage, the relief symptoms of cholestasis, for example, pruritus or jaundice, to treat cholangitis, to optimize medical status prior to chemoradiotherapy of the patient. Preoperative biliary drainage generally reserved for patients with resectable tumors who require timely biliary decompression for any of the following indications, like acute cholangitis, debilitating symptoms, expected delayed in surgical intervention, typically more than 2 weeks. This can be because of the neoadjuvant chemotherapy and sometimes because of the waiting list of the hospital. As for the cholangiography, as we know, most of the cholangiocarcinoma are perihilar location. And Gerald Klatskin described the tumor that bears the name. And when we decide the resectability, the extent of the tumor involvement in the biliary tract, vascular invasion, lobar atrophy, and presence of metastatic disease are very important. And in preoperative evaluation, imaging, staging, laparoscopy, portal vein embolization if we need, and biliary drainage is necessary in those kind of patients, because extended hepatectomy can result with liver failure and mortality. So preoperative biliary drainage and sometimes portal vein embolization improve the remnant liver function and decrease the mortality rate. In those patients, surgery typically involves an extended hemihepatectomy, including the caudate lobe and en bloc resection of the extrahepatic bile duct and regional lymph nodes. It's a big surgery. But in spite of this, preoperative biliary decompression is controversial. The best method, endoscopic versus percutaneous transhepatic, by which to perform preoperative biliary drainage is also debated. In this recent meta-analysis, routine percutaneous biliary drainage cannot be recommended, but it may be useful in highly selected patients suffering from cholangitis, malnutrition, and long-lasting jaundice for whom extended hepatectomy is planned. However, routine percutaneous biliary drainage cannot be recommended by those authors. But we can find the just opposite publications also. For example, in this paper, this year was published, and percutaneous transbiliary drainage is safe and effective in the management of biliary obstruction caused by the perihilar cholangiocarcinoma. And this is comparing the endoscopic biliary drainage and percutaneous transbiliary drainage for perihilar cholangiocarcinoma, and they found that there was no statistical difference between the groups regarding to the technical success, post-drainage bleeding, major post-drainage complication, and seeding metastasis. This is another study, and they are stressing that this kind of drainage procedure should not be done in the community hospital, and it should be done in experience centers, because it was an independent predictor for postoperative outcome center experience. This is another paper, and this meta-analysis showed that percutaneous biliary drainage has a lower rate of complication than endoscopic biliary drainage as the initial procedure to perform preoperative biliary drainage in resectable perihilar cholangiocarcinoma. And percutaneous biliary drainage is associated with less conversion and lower rates of pancreatitis and cholangitis. As you see, all of these papers, I think it is depend on the experience of the hospital and depend on the expert that they have. And general acceptance for all of these centers, if the serum bilirubin level is more than 10 milligram per deciliter and definitive operative intervention unit bilirubin level are less than 2 to 3 milligram per deciliter. And we do the biliary drainage also when the predicted future liver remnant volume is less than 30%. Imaging should be accomplished before doing such kind of stenting because artifact can make some difficulty to diagnose correctly to the extent of the tumors. If we don't relieve the obstruction, cholestasis can cause the liver dysfunction and biliary cirrhosis and postoperative morbidity and mortality. Because we do on those patients such kind of big operation and the future liver remnant volume and quality is very important. So because of that also we should have to do the biliary drainage before the operation. On those patients, we do also sometimes portal vein resection with the liver as it is shown in this picture. This is one of our patients with the portal vein resection. So those patients usually receive big operation. So biliary drainage is very important, I think, before the operation. This is a paper from the Japan, and they compare the percutaneous biliary drainage catheter and endoscopic nasobiliary drainage and endoscopic biliary stenting. And risk of portal vein injury and recurrence in the catheter tract when we use the percutaneous transhepatic biliary drainage is 5 to 6%. And peritoneal dissemination also can happen. The median time to recurrence was 11 months in this paper. As for the endoscopic biliary stent, stent occlusion is a risk and cholangitis is another risk. The Japanese Society of HPB Surgery Clinical Practice Guideline for the management of biliary tract cancer advise endoscopic drainage as a most appropriate method due to low complication rates. And in this paper, they compare all these three methods and they conclude that there is no differences between the three surgical methods when they compare. Okay. Another problem is biliary drainage should be unilateral or bilateral. Usually, unilateral biliary drainage and portal vein embolization increase the future remnant liver volume and has a positive effect on future remnant liver volume. But sometimes we need a bilateral biliary drainage, especially when the presence of uncontrollable segmental cholangitis or failure to decrease the bilirubin level with unilateral drainage. And sometimes we can add to this procedure endoscopic nasobiliary drainage or percutaneous transhepatic biliary drainage. Most common cause is cholangitis for the fever and cholecystitis and pancreatitis. In patients with endoscopic biliary stent, direct X-ray or to confirm the location of the tube CT is useful. Presence of fever during the biliary drainage, this means that patient has a cholangitis. We start the antibiotic therapy and check the catheter if there is a disposition or obstruction in the catheter and replace it with a new one. Fever, if lasting more than 2 to 3 days after catheter change, despite the adequate drainage, segmental cholangitis should be suspected, non-draining any other duct should be put inside of this duct, also catheter. Hepatic regeneration is reduced by the cholangitis, and potential focus for postoperative infection and mortality can occur and require a quick action. Is biliary culture necessary before the surgery? It is predicted which antibiotic will be used in the perioperative period if necessary, and the microorganism isolated in the postoperative period were 30 to 88% the same as those detected with preoperatively, and we identify the prophylactic and or therapeutic antibiotic by this way. In this study, usually they found the most effective antibiotic as for those patients, vancomycin and meropenem. Bile duct injury, another issue for biliary drainage, and cholecystectomy, as we know, one of the most common cause of iatrogenic biliary injury. And this is the classification system, as all we know, and some of them can be treated by the endoscopic biliary drainage. But for all injury, we must first find the location, degree of the injury, and presence of concomitant vascular injury. Small lateral injury can be managed endoscopically or with a percutaneous transhepatic biliary drainage catheter. But for more severe injury, percutaneous biliary drainage catheter can help to us delineation of the biliary tract anatomy and great importance in terms of therapeutic drainage, and allow us more secure anastomosis and help to obtain a cholangiography postoperatively to evaluate the integrity of the anastomosis. This is another patient of us with the portal vein injury, and we also use in this patient percutaneous biliary drainage catheter. This is another patient. As for the ERCP, patient preparation is important, adjusting medications, the management of antiplatelet and anticoagulation, antibiotic prophylaxis, and anesthesia. And it was mentioned, but if I have to say shortly, as we know, mainly there are three kinds of stent, covered metal stent, uncovered metal stent, and plastic stents. The median duration of patency for self-expandable metallic stents, there is authors here, but I found that more than 270 days, and for plastic stents is shorter, as we know. So plastic stents are effective for short-term drainage for patients with limited prognosis and expected overall survival less than 3 months. Uncovered stents has a low rates of migration between the 0 to 2%, and versatility may be placed in any part of the biliary tree and inability to remove because of the higher rates of tumor ingrowth than covered stents. And as for the covered metal stent, increase the risk of stent migration 6 to 8% and decrease the tissue growth into the stent and potentially removal, but possibly the reason of the cholecystitis in some patients. As for the adverse events, stent occlusion, stent migration, cholecystitis, cholangitis, bleeding, perforation, and pancreatitis. As for the contraindication, patients who cannot tolerate moderate sedation, monitored anesthesia care or general anesthesia, and patients with hemostatic disorders, patients who are hemodynamically unstable, patients with gastrointestinal luminal obstruction. As for the ampullary tumor, in the specific setting of ampullary cancer, in a retrospective series of 82 patients showed that preoperative drainage was associated with a significantly reduced incidence of postoperative wound infection. And but there was no favorable impact on other postoperative complications or survival. And they advise stenting only when there is a high-grade jaundice, more than 15 milligram per deciliter of bilirubin, and surgery will not take place within the following week. As for the pancreatic cancer, some surgeons routinely endoscopically placed stent prior to the surgery. Some surgeons reserve biliary decompression for patients whose serum bilirubin concentration exceed the 20 milligram per deciliter, in whom surgery will be delayed for longer than 2 weeks, and in those with debilitating pruritus or cholangitis. Cochran reviewer had concluded that stent patients had significantly fewer postoperative complications, but similar post-surgical mortality. But after this paper, recently, in meta-analysis, there was no significant differences in mortality were seen, but overall serious morbidity was higher in the preoperative drainage group. This is another meta-analysis for the patient who are receiving the chemotherapy before the operation, neoadjuvant chemotherapy. In those kind of groups, they are advising the metallic stents. This is another paper in patients with pancreatic head cancer, technical success and complications and severe postoperative complications didn't differ between the patients with bilirubin level more than around 14 or 15 and less than 14. So they conclude that their study does not support a different approach regarding to the percutaneous biliary drainage in patients with severe jaundice. This is another paper comparing the endoscopic and percutaneous biliary drainage for resectable pancreatic head cancer, and they conclude that from the operative perspective, patient who underwent percutaneous transhepatic biliary drainage in perioperative setting had fewer morbidities and shorter hospital stay. For the metastatic disease, clinical skill of the surgeon using the intraoperative ultrasonography, excellent theoretical knowledge, oncological and anatomical new insights is important, but preoperative biliary drainage is also necessary for some metastatic occluded tumors. This is a paper from the Professor Makuichi. Risk assessment is very important. With this algorithm, more than 1,000 patients were operated. But as you see, of course, this is for the cirrhotic patient, but bilirubin level is very important. And more than 2 milligram per deciliter bilirubin level for the liver resection is very dangerous. This is when one of the patients, some of the tumors are occluding to the bile duct after the operation. Those pictures, those other samples of our patient with the multiple metastases. So, to doing such kind of major operation, if the patient has a biliary obstruction, to relieve the biliary obstruction is important. My last slides, I would like to notice maybe for you also the same. In practice, the majority of the patients who present with obstructive jaundice will have been stented by a gastroenterologist before the diagnosis is established, and it is known whether or not the patient is surgical candidate. This is the practice in my hospital. I don't know how is it here. So the surgeon usually has little influence on the decision. Thank you very much.
Listening to the presentation by Professor Dulundu, I think we can have a open house session if somebody wants to ask any question. It'd be nice if we can have some active questions, or should we ask our colleague, Dr. Selva, take over the questions. I think we will call Selva, and then in the meantime, we can have more interaction, because then there's a huge list of questions which we can discuss with this important topic. So Selva can.
Once you finish, you can take the questions from the chat.
Good afternoon, everyone. I first of all would like to thank Professor V.K. Kapoor sir for inviting me for this conference. I have a couple of questions. These questions are based on the practical clinical scenarios we face and the dilemmas we face. So one scenario which we face is a patient with periampullary malignancy who doesn't have renal failure, but the creatinine is on the higher side. It is probably pre-renal component. The creatinine is 1.8 or 2, and the bilirubin is more than 25 or 30. So in these patients, what do we do first? Whether we do biliary drainage to let the renal functions normalize, or we just hydrate the patient and manage the patient conservatively and do a CT before doing before placing a stent in the bile duct. Because as you had mentioned, sir, a stent in the bile duct may compromise on the assessment of the tumor as it creates artifact in the CT. So
Selva, this question is to Dr. Dulundu.
yes, sir. Yes, sir. 1.8 creatinine level, but the patient is having a good urine output, and patient is not in cholangitis. So should we do a biliary drainage first, or should we wait by resuscitating with IV fluids and then go for a CT before biliary drainage?
Urine level is treatment for the renal function, and patient has already high level of creatinine level. If he hasn't got any cholangitis, but eventually, I prefer to hydrate the patient, and after that, I took to biliary drainage catheter, and then for imaging moderate.
And then
So if we are looking at right, so in that because bilirubin was 20, this creatinine was 1.8, you would like to hydrate to get the creatinine well. But just because bilirubin was 20, you want to stent him. Am I correct? If suspected periampullary malignancy.
Yes, regular cholangiocarcinoma. For myself, my main target will be below the 3 or for this certain station has received very advanced.
No, he's talking about periampullary, not perihylar.
periampullary malignancy.
I thought he's talking about very large.
Lower CBD tumor.
So in this situation, maybe under hydration and
The creatinine level is optimal, we'll stage the patient and then you can take a call according to staging. See if it's a borderline tumor, you might have to plan a newer approach in penetrating set and waiting period would be nobody would give a chemo unless we drain the patient and get the jaundice down. And this upright section, you can resected without biliary drainage. Because biliary drainage in these patients, we don't have an exact cutoff. But there is new literature. I have seen just 2 articles that say that very high bilirubin level SR is typically correctly do not give a good long-term survival. All those infective complications are more related to biliary stenting in an unrequired situation. And many of us are proponent of not stenting the patient and going for upward surgery. But there are 2 scenarios where if you have to give it adjuvant chemotherapy, neoadjuvant chemotherapy, and if the bilirubin is very high, since we have Occasionally we get some sort of patient where we will be somewhere between 20 to 30, 33. People say that they don't see more than 33. We should sometimes become 33, 34. For those patients, it's not upright to take momentarily good advantage. And we will have to take opinion from others as well.
Ma'am, a question for you, ma'am.
Is your first question solved?
Actually, sir, it seems the consensus is to go for biliary drainage rather than CT first.
No, why not? If your creatinine is down, there is no contraindication of
I think if I put in 5 lines, once you have a normal bilirubin now, let us stand there. If it is resectable, go ahead with resection. If it is unresectable, borderline, then go for a neoadjuvant therapy, and then subsequently go ahead with resection once the neoadjuvant is complete. So the primary target is to get the creatinine down, and bilirubin is not the mark.
Okay.
Sir, it may not be the marker like standard is not yet, but it depends on the institutional policy.
I just that's what I wanted to ask actually, Dr. Dulundu. That was my intention to ask that question. When he said that when the bilirubin is 20, like you said, sir, do you stent when your bilirubin is high for a lower CVD obstruction? If the patient is not having cholangitis,
Yes.
do you stent this patient
Yes.
or you directly go ahead with surgery?
Only for the periampulary.
Stent. So what is the level above which you will stent? Suppose the bilirubin is 8, where you stent? Above 10 you will stent, below 10 you will directly go for surgery.
The waiting time is not long.
So it is an institutional policy as Bhakti mentioned. I think
It is standard for what in 10 how long will you wait? What would be the lowest levels?
okay. So we have a sequence question now that the patient had a bilirubin of state 11 and now you are stented. So for how long will you wait? Am I correct? That's what the question is. Or is this only correct? Presently we discuss only for areas.
Yeah.
Okay, we come to that question in a minute. I think we can first take over this question. Suppose the bilirubin is 11, the question is, and you have stented for a periampulary, lower CVD cholangitis.
If I start, if I put start or then for no to also that usually 2 milligram per deciliter every day. So we can one for instant.
So it is there are now 2 things which are clear. One thing, it is an institutional policy. Professor Dulundu's policy is bilirubin about 10. When we were at Sunday PGI, our policy was bilirubin about 15. And now presently what we are following is we don't limit to any high limit of bilirubin. We do it up to any bilirubin. So that depends upon the institutional policy. That is one thing. Second thing is once you have stented, if you have stented the patient, you should wait long enough for its bilirubin to come down to maybe something around 2, so that you are the patient in the best of the sleep. Once the third thing is once you have stented, as you said, it will come something around 2 milligram per deciliter per day. It is around 20% per day, which it comes down. So the graph gradually it takes about 7 to 10 days for it to come down from 11 to the common level. So maybe you will have to wait for that. I think I hope I am clear. Yeah. So there is some another question which was
Just one second. Suppose there is a bilirubin of 15 or 20, and it's a different institutional policy for drainage for periampulary carcinoma. So is there evidence to wait for waiting in the level of close to it's not for the higher level?
no. There is no evidence for that.
Right. This is only there is data for upper top, but there is data for lower level.
It is only because once you have stented, you would like to have the patient in the best of the conditions to operate.
And I think there's no fixed time period that how long you have to wait, but it's the ability, by not all patient that it comes down with the 2 milligram every day. But it depends on the rapidity of the calls. Ideally, you have to take the benefits of getting once you have pending the
Because problem is with higher velocity is that normal rate, there is an intermittent descent of coronavirus. So the patient comes at the descent of coronavirus and you have.
I come to that. Let's come to that. That's a very important point which you have raised. We come back. I think we can have a discussion for the whole day on this further because that is the area of very hot interest of a department which we have on this discussion.
In fact, when you go for the periodic drainage, instead of plastic descent with short line, measured drainage.
Yes, yes. So we come to that. I think any more questions from the residents on this that will be preoperative for a perioperative carcinoma? No. So we can take for the next question. You would like to take question from chat box or you have your own question directly first?
Sir, I have a couple of questions. Sir.
Okay,
Ma'am,
sir, I hope you don't have time yet. Because the time
We have 10 more minutes.
10 more minutes. We have ample of time.
once in a while we see patients of periampullary or CA head of pancreas who present with acute pancreatitis. So in these patients, like how long should we wait before we plan elective surgery? They are operable disease, but they have coexisting pancreatitis on CT, either on imaging or clinically they present with pancreatitis.
By and large, these patients do not present with those kind of severe acute pancreatitis and necrosis, whatever we have seen. There is much difference connecting to this area, but this is one of the mode of presentation in very cancer. So as the patient is locally stable, and it all depends on your requirement of staging C. Because a lot of edema and some critical agents might also be altering your exact staging of the disease. So accordingly, you have to take a call on the clinical response. Why acute pancreatitis, why to moderate, set it down over a period of 1 week or 10 days. We would because fall into that subset of patient was severe acute pancreatitis sick for months together, 40 days or 2 months. The priority is to make a plan for a perioperative malignancy, depending upon the severity and requirement of plus minus set as we write inside the policy. We also take plan of 50 or 70 maximum, but we don't overlap with certain patients. Very and pancreatitis, I don't think of wait for months together. So there's no time period as and when your patient is clinically fit, as only for this how early go for an endoscopic clearance of CPT soon, that will you have to go for your whenever your slot is available, pick up the patient for
And repeat imaging can also have a role in this planning for surgery. Like once you have like previous images of suggested pancreatitis, you want to see after 2 or 3 weeks or 4 weeks, like imaging whether those inflammatory like parameters have settled down or not. Like depending, like if those are persisting, you may wait further. Otherwise, if everything is settled down, you can plan a surgery.
Okay, let me in 2 sentences. If it is a mild pancreatitis, you can go in early. Don't have to wait for a long time. For the severe pancreatitis, do a repeat investigation before you go for surgery. But it is better that you should have a normal pancreas when you are going for a PD, specific about PD.
I think more common scenario would be a post-intervention pancreatitis rather than upfront pancreatitis with malignancy. If you treat patient, these patients they go to restaurants, they go to IASGO President, and then patient develops
Pancreatitis. Yes.
So how frequently you come about this study and your problem of waiting for pancreatitis, which has been
He said he had this small experience that recently he operated 2 patients. That patient had a mild pancreatitis. He went in on 3 weeks, and it was like a very difficult surgery. So means it was ampullary tumors, small tumors, but the regions were very dense in the body. So I think we were regretting, but ultimately we could complete that. So I think this is a pancreatitis. It's not a bad idea to wait for maybe 6 weeks when we classically say the inflammation settles, and how we don't get this guideline and this complication is very less. So
I agree with you. There are actually 2 scenarios which we have to understand. For the pancreatitis, it is one thing going in difficulty going in, and the more difficult area is to do this. within. So take care when you are going in that you are having an infilled bag.
Ajay, with your permission, can I request Abhinav to make a comment about this point mentioned in passing plastic versus short length assistant for temporary pre-operative biliary drainage before very good. In situation like ours, we have like cost conscious patients and cost with their restraint. Short length plastic stents are, I think, they're cost effective, and if not placed for too long, they would not pose any difficulty like very cortical inflammation. But if we obviously put them for a long time, like
So given a choice, if you have low cost constraint, you would like to put in a metallic stent or a plastic stent?
I would still like to place it plastic stent. Because the another problem with the metal stent is they have high tensile force and they compress freely. So my I have a fear of more pancreatitis happening because of compression freely due to metal stent first.
Important part, that's why I don't want to that.
Do you have any experience of using these short length metal stents for temporary preoperative biliary drainage?
Also, if you
It's operation. You know, sometimes plastic attempts and some inflammation elements. So I actually also play yes, operation.
Sir, in the same topic, sir, plastic versus metal stents. Should we prefer metal stents for patients who are going for neoadjuvant? Sir published sir showed a slide also on that. Like nowadays we see patients of CA head of pancreas or locally advanced CAGB, but they are not metastatic on imaging, who are going for neoadjuvant therapy. In them, we do see patients who come back between 2 cycles with stent block cholangitis, and they are usually severe forms of cholangitis. So in these patients, should we prefer metallic stent over a plastic stent? Just this subset.
Yes, the advantage in metal stent is that they have more diameter. So obviously their patency rate is high. And what you are saying is right, with the cholangitis rate will be lower if yeah, that point is right.
How easy is it to deploy a metal stent in a hilar block?
No,
The lot of That's a general question for Dr. Dulundu and Kapoor. Maybe other people can take it. That suppose a patient comes to you with a stent. The patient had a bilirubin of 5. He has undergone a plastic stent elsewhere. He comes to you 2 days after the stent placement. When will you operate? He did not have cholangitis. His bilirubin was only 5.
The bilirubin to begin with was around 5 milligram, but for whatever reason, as you said, a stent was placed and patient comes to you after 2 days. Would you operate now or would you wait? Yes, yes.
And that was
2 days
ago.
2 days ago. Or maybe yes.
Pardon?
Or we wait because if there is they already understand just has done his job. So because of that, I can.
So you like to wait.
What was the indication of
There's no-
waiting? I think there is no need to wait because it was just because endoscopy was done, ERCP was just and it was fine. Obviously, don't say he wants to wait.
I don't think we will be ready for the next months because if it will already for in a very short time, it has to be.
Problem with the stent you have taken in this patient. You have stented the patient. So now it is better to wait for 2 or 3 weeks. Now the pathophysiology has to take corrections. And when patient is fully optimized, bilirubin has come down to 2 or 3, then only to operate. It is 5, but it can come to at least. But I think that will not much of a difference from 5 to 2.
I think time period should be important according to how response it has created. If it, I like how we talk about bilaterally, you can go in very early in the bilirubin was optimal. But if it has generated a lot of reaction, if they come to you at wrong times, around 12-15 days post-treatment, then it's genuine enough to wait for some time.
Longer than stent remaining people longer before it is a plastic stent. And then in between, suppose it will block again the cycle of cholangitis.
Can always somebody can have a stent blocking.
Or stenting like cholangitis or renal failure, malnutrition, something like that.
So let me conclude in just 2 sentences again. Go and end with those sentences. So what it is that if the patient is stented, we only wait for a longer time so that the inflammation comes out because of stent which has happened. We are worried that because of stent also there is some inflammation or it can lead to obstruction, subsequently a stent obstruction cortical injuries. So we may not wait for a longer time. If as long as your bilirubin is normal, the patient is fit, you can go ahead with surgery. That's how I take it. Maybe everybody has his own principle of taking it. So I'll not like to wait for a longer time. But if somebody wants to wait till 2 or less bilirubin, I don't mind it also. But you have to be cautious that stent will come. Next, Selva.
Sir, questions in the chat box. Is pruritus an absolute indication for preoperative biliary drainage? How to follow LFT after preoperative drainage? When to repeat, or is it even required to follow LFT?
We of course need to follow pruritus. If it is already debilitating, that the patient is awake for whole night, and different patients have different level of pruritus. It's not related to the depth of jaundice. And if it is that debilitating, it can be an indication even for drainage in some patients. Many patients pruritus is managed by all those cholesterol stemnate and some amount of sedatives to give some peace to patient pruritus. But as such, for a definitive indication, only pruritus cannot be an indication for early evaporate. It's all depending upon the stage of the disease, as well as it also depends upon the amount of hyperbilirubinemia, your policy. The likelihood of these patients who have pruritus, which is very disturbing, to have high bilirubin, and if you have a policy, then you set it. And then you wait for the symptoms to settle as you have a bilirubin. But if it is the only symptom is bilirubin around 5, then you plan an early procedure, operative procedure in these patients. And followability always there. It depends on the rapidity of one LFT for these patients. When it was a definitive proper indication of
Alarm already going on. Last question. I think we can find another question.
You, Professor. And now the recent literature is coming up for liver resection without upfront biliary drainage. I'm talking about perihyaloclone, especially left-handed resection. So I want to know your experience for liver resection without biliary drainage, and if yes, what is the cutoff bilirubin level for these kind of liver resections? Especially left side.
I always wait for the bilirubin level below the 2. Yes, I will not do above the 2.
But I agree that what you should say, there's a lot of literature which is coming up that you can go into the liver resection without getting the bilirubin down. And almost all of these, I think there's not a single study with the right hepatectomy. All of them have been the left hepatectomy. With the bilirubin of even 8 and 10, they have shown. But they have not shown that they require decrease in bilirubin. We wait for the bilirubin to be 2, but the literature is coming up, maybe it will change the trends. So we can conclude. Thank you. Excellent presentation. And definitely a good questions. Thanks. Thank you.
Thank you, esteemed Chairperson and Dr. Dulundu for his pearls of wisdom for preoperative biliary drainage. It's a vast topic. No, so now I would like to call upon the dais to chair the next session. Our esteemed Chairperson